diverticulum. We may want to take time to think about diverticulum. We have two diverticulum whole GI system. Number one is we say traction type. Another one we call the Persian type. So in terms of Persian type, this is we say false diverticulum because it's not about whole 5 layers over the esophagus. And it happens in the upper esophagus. And then the typical one is a Zenker's diverticulum. Usually the diverticulum is grow from the center to the behind. Another is from center to the front. Anterolateral, we say Killian-Jamison. So Killian-Jamison is we endoscopists do not touch this one because it is adjacent to recurrent laryngeal nerve. If we do treat this one by endoscopists, the patient suffer permanent hoarseness, cancer. So don't try this. You just ask the doctor ENT to deal with this. But for the Zenker's diverticulum, it's easy for us to do. If we do the deep poem, so we can resolve this quite easy. And then I would say about the transthoracic plane, which we usually say that the Ludwig's plane by Grace illustrations. This is very important and interesting pictures. And then this is we say, right? I cannot see it. It's okay. The red one is we say right bronchus, and then esophagus is just adjacent to right bronchus. It's like this. Cannot see it. Okay, this is esophagus. After esophagus is the vertebra, and then left bronchus, and then aortic arch. So it made quite complicated over the Ludwig's panel. So once this, we can figure out which part can encompass the esophagus. Maybe esophagus is influenced by vertebra, or influenced by left bronchus, or aortic arch. It can make these beautiful features when you do endoscopies. And then we can see that which one is a lung cancer embedded to esophagus. Sometimes the vertebra is so big can encompass the esophagus, or aortic arch can make any canal between esophagus and aortic arch. And we can know about vertebral anatomy. And after this, we can figure out the sorting out a lot of diseases over the thoracic plane, like the beginning from squamous cell carcinoma and drug-induced or pill-induced esophagitis, or bronchoesophageal fistula, or radiation esophagitis, or foreign body esophagitis, or tuberculous esophagitis, which is the real type of diverticulum. I'm going to say a little later. And immune-mediated esophagitis. Unfortunately, motility-related esophagitis, we cannot diagnose by endoscopy. We need manometry. So the first one is the bronchoesophageal fistula. It's quite interesting. If you sit on the forecast, you may see the patients may say, "Oh, doctor, I have the consecutive coughing. If I lie down or even upset, but it's gone if I numbs up." So this is an honor sign. It's very pathognomonic. You can diagnose easily. This we call benign bronchoesophageal fistula. And nowadays we can treat by endoscopic vacuum therapy. But the tuberculosis, as I mentioned, this is a true type of diverticulum. So we say traction diverticulum happens in the Ludwig's panel, which is the vertebral anatomy 4 and 5 areas. After you treat it, the diverticulum still exists because this is a traction type. Whole layers from mucosa, submucosa, muscle, and then adventitia, they're all outpouching. And then sometimes there's many interesting features. I occasionally found that the very dark spot over the disc, we say anthracotic pigmentations found. Sometimes submucosal lesion over there. And if you do EUS, you can find some lymph node or lymphadenopathy This is all tuberculosis. And this Behçet disease, I realize in Vietnam, this Behçet is quite scarcely found. I feel strange because in my country, it's very common. So Behçet disease is not infectious, but this is immunologic. So it never goes the obtuse angle like this. So obtuse angle is usually Helicobacter pylori ulcer, is obtuse angle. But this is immunological ulcer, so either acute or right angle. So like this is really punch-out region. And sometimes we can see accident on the base of the ulcer, or sometimes the mucosa the surrounding the ulcer is very normal. This is typical in Behçet ulcer. Other than Behçet ulcer, also Crohn's ulcer may be possible. If you are interested in Crohn's, you need to remember Montreal classification. By Montreal classification, number one is age, usually age 1, which is below 16 years old. And number 2 is L, location-wise, L1 is the large bowel, L2 is the small bowel, L3 is the ileocecal, L4 is the upper gastrointestinal tract. So AG1 and L4, this is both esophagus and stomach is easily compromised. And then in particular, this is TTP areas. And this is very interesting, but most serious one, we say is phagia megalotriensis. This is because of the sweeting left atrial appendage enlargement. When sweeting is the left atrial appendage is enlarged, so a little below the transthoracic plane is getting more narrowed. And then when the peels of is combined, it makes a very huge ulcer. And then needless to say, it is affected by recurrent laryngeal nerve crisis. So patients mostly have cancer. I say, I suffered. So this is quite an interesting feature. And this is not rare, this is early esophageal cancer. But when we say early esophageal cancer, our endoscopists cannot do anything except surgery. But when the early type of early esophageal cancer, we can treat by endoscopies. Unfortunately, normal white light endoscopy we cannot diagnose, but we do employ MBI as a near focus, so we can see the kind of B1, B2, and B3 classification. This is the most serious one. I might have experienced just one case. So when the aortic dissection happens, the aortic dissection is overlapped by descending aorta adjacent to the esophagus. But this is reserved for So the vertebral anatomy, we say T5 to T8 areas. So after the TTP, if there is something, the big ulcer, seeing this, please don't proceed. Let me repeat again. Please don't proceed your endoscopy. Just stop it and finish, and then take CT scan. Because this is most serious one. If you proceed, if you're going back, you can see the bleeding pumping, like the real pumping. This is a heroin bleed. It's very specific disease entity we call it heroin bleed. And I'm sorry, almost 100 patients will die on your endoscopy. So whenever you see those things in the T5 and T areas, stop endoscopy and then carefully taking either just echocardiography or CT scan, ask your cardiologist colleagues to do stent, and then you can save the patients. So last one, so granular cell tumor is not common, but it's not rare. Sometimes you can see this one, and now it's easily treated by endoscopy. And this common ulcer, it happens after hiatal hernia. So hiatal hernia has many ulcers over the herniation areas. Interestingly, in the chest PA, lateral PA, you can find that the air pocket is easily diagnosed. Let me introduce the achalasia, but not common achalasia. There are two specific sequela after long-standing achalasia. One is the epiplatic diverticulum. Again, this is not traction type, this is the Purton type. So Purton type means we can treat by endoscopy, like a COVID, we can treat this. So if the achalasia is the times long enough, and then you can see the thick diverticular septum, and the bigger it is two lumens are tangentially opposite, and bigger one usually falls diverticular, and the true one is a smaller one. So you can, if you check barrier edema, it's much easier. This is an epichronic diverticular. The last one is quite interesting one. You can see the mass in the chest X-ray. So 우중특 So this is 우중특 but this is not two type of U. This is esophagus. So how can we know? When we check the value, still we can see taper distal narrowing with a bird peak appearance. When you check CT scan or MRI, it is really synchronized by chest X-ray. So eczema group is the not 우중특. This is esophagus. The most important one is the endoscopy. We all know when we do endoscopy, it's very difficult, but we can see the pump on the tummy areas because achalasia is never allowed endoscopes go in. But in this case, it's very easily. So endoscopy goes through the tummy very easily. Why? Because the auerbach plexus be far head So from tummy and then upper esophagus, all motor function has gone. This is the late stage one. End stage of ecology. So it's not, some esophagus diseases related to the Chen but others is not. Let me choose two specific ones. One is the Niemchung infectious, and another is the AOA esophagus. So in terms of infectious, please don't consider a lot, only three: Candida, and HSV and CMV. But by pathophysiology, Candida is only on the mucosa nemma, so it's easy. I know that some high volume hospitals you can see Candida esophagus every day, but HSV and CMV is quite interesting. HSV is only nemma. So like this, when you have the HSV here in your mouth or nostril, you can find the bullae or cyst over there. And it usually comes out. Same as esophagus, because we eat every day, we drink every day. It's easy to come out. However, CMV is different. CMV is from the mouth. It's from the deep tissue and flowing up to the lumen of the esophagus. So usually this is a zoenemma. It's not nemma. So HSV is nemma, CMV is a zoenemma. How can we know this? This is a HSV. This we call a volcano. So after the eruption, so the surrounding areas has still viral particles. So please do biopsy on the rear. But CMV is different. CMV is like a really something-like, snake-like. So please biopsy on the center. If you biopsy on the rear, you can't find the virus. Only in the center, because it's from the deep vascular structure. Eosinophilic esophagitis has the three phases. The phase number one is the motility. So this motility. Phase number two is the inflammatory. Phase number three is no matter what kind of vaccine, it's only stenosis. So we have the three different modalities to diagnosis. Usually by endoscopy, VM with biopsy, we can find out. So again, it has many phases. It's difficult, but please take care of the patient history. You can find this. So radiation esophagitis is another very important issue. Nowadays, many high volume hospitals do radiotherapy on the chest, like lung cancer, breast cancer, and esophageal cancer. Those three cancers need radiation therapy. After radiation therapy, we need to wait until only 2 weeks. And some of you already experienced radiation tonsillitis, but Jukchang is a radio insensitive organ, which means that after radiotherapy, the VM Jukchang, you need to wait 1 to 3 months because Jukchang is a radio insensitive organ. Jukwan is more sensitive. So earliest is the 2 weeks after radiation. After 2 weeks, it is foliative or inflammatory or ulcerative and bleeding happens until 4 weeks. So 2 to 4 4 weeks after radiation, the radiation esophagus may happen. Whereas all the boom, it means the 1 or 3 months later after surgery. So the one is both and back and south, but this is only head one south, very possible. Head one south and one south is an acute club, but after 8 weeks is man. So man is the head. So we need to understand where the patient on the steps. This is sloughing esophagitis. Now we have a lot of medicines, NSAIDs, and then DOACs. After NSAIDs and DOACs and mass, this squamization happens on the esophagus. We say sloughing esophagitis looks serious, but it's easy. Just stop taking medicine, and then some PPI, wait a couple of weeks, is better. So melanosis, melanoma is important for us to differentiate. Melanosis is basal cell hyperpigmentation. Like this, sometimes we can find a black spot, black dot over the esophagus. Sometimes we can see the real one, this melanoma, truly malignant. We need to ask our oxybomero to immunohistochemical staining is S100, HNA45, melanoma, etc. And last one is a squamous cell carcinoma. This looks really serious. This is benign. Don't worry too much about it. But I do encourage you to do lugal endoscopy. After lugal endoscopy, you know the esophageal cancer destroy all the glycogen. So if the glycogen destroyed, it's no dye stain by lugal. But this is well dye stain. This is benign. Don't worry about it. And this is just the skin and the sweat gland also happens in the esophagus. Don't worry, this is benign. You don't need to take every